Good morning, Miss Barami. Good morning, Miss McDonald.
Good morning, my lord.
Right, when you're ready, Miss
Thank you,
Barami.
my lord. Our first witness is Duncan McDonald from Erskine Care Home in Bishopton. Mr. McDonald has provided a witness statement. The reference number for that, for the record, is SCI WT 0421-501. Mr. McDonald, you're a house manager at Erskine Care Home in Bishopton, is that correct?
I was a house manager during the pandemic.
Thank you. Now, Erskine is a charity for veterans, which, among other things, has 2 care homes, one in Bishopton and one in Gilmerton in Edinburgh.
Yes.
Is that correct? And Bishopton has a capacity of 180 residents, while Gilmerton has a capacity of 40 residents.
Yep, that's correct.
Thank you. Can spouses also move in with their partners?
Yes, they can.
And each care home has a number of houses within it.
Yes,
right?
so Erskine Care Home, the largest, had 180 residents, split into 6 different houses of 30 residents in each house.
Thank you. And you were the manager for Hague House.
Yes, I was.
And the residents of Hague House had dementia to varying degrees. Thank you. And at the onset of the pandemic, there were around 30 members in residents in Hague House, as set out. And you had responsibility for around 40 staff members in Hague House.
Yes, I did.
What were some of the activities and services that Hague House provided or Erskine provided for the residents prior to the onset of the pandemic?
So prior to the onset of the pandemic, we had activity staff on site, so we would have concerts out within the home. We had a large activity area that all the residents could attend, so large concerts, football matches that were on. We had religious services for different faiths. We had in-house concerts as well. We brought in petting zoos. We had donkeys, horses visiting, plus also trips out as well. So we would use, go to different areas. We had coaches or minibuses on site as well we could use. We did that for a lot of trips. Pretty much every single day there was activities on for the residents, so whether it was in group activities or whether it was individual activities.
Thank you. And that all stopped when the pandemic started. Yes. Did Erskine decide to stop those activities prior to the official commencement of lockdown on the 23rd of March, or was it on that date?
It was 4 years ago. My recollection is a bit hazy at the exact times, but I know that right up until we had to lock down, we still, as much as possible, had activities with it. We segregated them to house activities rather than having different houses mixing, but we still had activities for the residents within Hague.
Okay. And did you allow visitation up until you weren't allowed?
Yeah.
At paragraph 12 of your statement, you say that the layout of Hague House made it easy for you to distance the residents. You say there that you could separate them for dining in small groups and using the lounge in small groups. Was that after the restrictions had been put in place?
The layout of Hague House is it's like a hub or a spoke, so each resident, each corridor had 10 bedrooms, but they had their own dining area and lounge area within those 10 bedrooms. Other houses had a communal dining room for the 30 residents. Okay. So we could very easily in Hague, and it was just because of the layout, because it had been designed as a dementia house, we could very easily segregate people into just 10 residents in a small area rather than having the 30 residents together. So it made that easier for us.
And they were kept separate to the residents of other houses?
Yes.
And you also suspended the admission of new residents at that point, is that correct?
Yeah.
You talk in your statement about updating guidance as soon as changes were made. How were you able to do that? Did you have to, we've heard from some care homes, they had to have their plans approved by people within their organisation and some by external organisations. Was that not a requirement for Erskine?
So, yes, we had an internal quality improvement team that worked on site as well. So they, when the information came through, and it was always a Friday afternoon, Friday evening, they would disseminate the information, see what we were doing that was different from the guidance, and then they would very quickly either put out posters or put out information telling us what the house managers had to have in place to, you know, to keep up with the guidance then.
Yeah. And was that quality improvement team set up prior to the onset of the pandemic?
It was.
Were they based in one of the two care homes, or were they?
They were based in the main care home at Erskine, and they'd been there for years prior to that, but very quickly their real focus became IPC.
And that seems to have made quite a difference.
Yes,
for
it meant that
Erskine.
as house managers we didn't have to go through the guidance, we had it given to us like very quickly.
So you were able to focus on
the
your
residents and making sure that we were following everything that should be getting followed.
Thank you. You state that you had no deaths during the first wave of COVID.
No.
Is that correct?
That's correct, yeah.
And later in your statement, you state that 5 residents of Hague House died throughout the duration of the pandemic, and a number of others, a number of other residents in other houses. Were those 5 all COVID deaths, or were they?
They were
total?
put down as COVID deaths. You can never tell. You know,
Okay.
we have a population of residents who are elderly, a lot of comorbidities. Some had been actively dying before the pandemic even started. You know, it'd be difficult to say that COVID was the reason, but it could have been a contributing factor.
Thank you. Once the restrictions were put in place formally, how was your work affected?
So it was really just staff were scared at the time. You know, with the restrictions that were in place that were changing all the time, it became more of, we always tried at Erskine to make it person-centred care. You know, it was all about the residents, but very quickly it became all about the tasks, about the cleaning, making sure that we were following IPC guidelines, making sure that everything was cleaned and it was recorded, because the recording was so important as well, for proof. And very quickly the focus went away from the residents to everything else that we had to do and make sure that we were following guidance.
And what was the impact on your mental health? I understand from your statement that you were also dealing with your wife's cancer diagnosis, and that treatment had been stopped.
It was a scary time. I didn't know, I didn't know if I was taking COVID into work with me. For my residents, who obviously are all, you know, quite susceptible, or if I was taking COVID home to my wife, who had been told that her treatment had stopped because if she caught COVID, you know, it would be a serious problem for her illness. So either way, but it's the job that we do, you know, so you still turn up every day and you did it, but it was just hard, and it was a 24/7 job.
Yes.
It didn't stop, it didn't go away. You went to work, you came home, and you went back to work the next day. And it just took over your entire life.
And can I ask, how long was your wife's treatment stopped?
So it was stopped from, she was due to get chemotherapy in February. We went to the hospital and she was told no, she couldn't get it because that was right just as the hospital was locking down. So she was told no, she couldn't get it. She had to go back home again. And then as soon as the first lockdown lifted in June, she went back in and got the treatment then, and thankfully she's absolutely fine now.
Glad
but,
to hear that.
you know, at that time it was quite a difficult time.
Yes, imagine. Thank you. How were your staffing levels affected by the pandemic?
It was up and down. You know, we couldn't get an agency staff because we couldn't bring people in from other places. So it was only like Erskine staff. They did a lot of extra shifts, but a lot of people, at that time there was no testing. So if you had any symptom at all, then you had to isolate. So staff were going off if they just felt unwell, you know, had a sore head, were having a cough. We couldn't take that chance, so they were going off sick at the time. And they were, at that time it was a 14-day isolation, so it was a long time for staff to be off. So staffing levels, we should have had 8 staff for 30 residents, and some days we had 4 or 5, 6 if we were lucky.
Did that have an impact on the care that you were able to provide to residents?
Yes, and it was just cumulative, you know, it was just like less staff, less time with the residents. The time with the residents was cut back to the bone anyway because we were doing so much cleaning. You know, less staff to deal with everything else. As a manager, you lost all your management time, so you were working on the floor, so you lost all that time that you had to do your management stuff as well, so everything else became out with work. But for staff, it was tough. You know, they were going to be short-staffed pretty much every day.
And were staff able to gather in a staff room or to speak to each other and support each other, or was that very much stopped as well?
Within Erskine, they had a cafe that we could all attend to before COVID. Once COVID started, that closed. You were into your house in the morning, you stayed in the house for the duration of your shift, so that was at 12 and a half hours. You stayed in that house. We, at the start, didn't have a break room within Hague, so we ended up having to use residents' bedrooms as they became available. But again, we had to cut that back because of the distance requirements. We had like 2 members of staff in each break room, and that was it. So it was like you and someone else.
Thank you. You say in paragraph 21 that by the end of February and into March, and that's before the start of the official lockdown, you had a couple of residents with respiratory symptoms who were at the end of life, and residents were allowed to visit with full PPE on.
Yes.
Was Erskine requiring relatives to use PPE before the official guidance?
Yes, I think it was just our director of care quickly realised that you could see on the news it was coming, you know, so it was just a matter of just to keep the residents safe as well, and the relatives safe, you know, as much as possible. We still, all the way through COVID, at end of life, residents came to visit, but they had to wear the full PPE just for their safety as well. Yes,
but at that point, it was clear to your directors that this is a precaution that should be taken. We've heard from others that it was difficult for those in the care sector to see the appreciation for those in the NHS, whether it was clapping, special shopping hours, discounts in shops, free coffee and the like, as it made them feel underappreciated. Was that also the same sentiment and feeling experienced by staff at Erskine?
Yes, social care has always been sort of the poor cousin of care. I've got friends at NHS, and you know, massive respect for them, especially during what happened. But we felt that, we were setting this again at the start. You know, PPE had been redirected to the NHS, so we were struggling to get PPE. I had all my people in my street out clapping for the NHS every Thursday night. You know, and fair play to them. But we had to get letters from our director to say that we were working social care, could we get in at the shops at the same time, and even the end staff were getting turned away, you know, and it's embarrassing to get turned away for shops. But it was definitely the same sentiment from Erskine.
I think we touched on this briefly just before, but at paragraph 26, you mentioned that at times guidance was changed on a Friday, and it was an awkward day as you had to make changes before the weekend to ensure things were up and running quickly for Monday. We've heard that not everyone was able to achieve that. Some care homes had a delay of a week or two because of how things were set up. Do you think the reason you were able to do that was solely down to your quality improvement team, or do you think there were other factors that allowed that?
I think that was a massive reason. I think, the reason that they could, and we also had internal communications, so we used a platform called Workplace. It's like a meta company. It's very like Facebook, but it's locked to the company, so we could they could very quickly put information out on that. They could put posters on that for us to print. And we could very quickly see that. So it was, the QI team was a massive plus for us to have them. We didn't have to go scrabbling ourselves. The other thing that we had within Erskine was that managers didn't just work Monday to Friday. We worked internal rotation, you know, so we were sometimes available at weekends as well to make sure that was getting in place before the Monday, and we never really wanted for any equipment. Erskine always provided what we needed to make sure that we were following everything.
Yep. Thank you. In paragraph 30, you state your management guidance was clear but just changed quite a lot. By that, do you mean Erskine issued its own guidance for management purposes? And did that seek to implement government guidance, or was it in addition to government guidance?
I think what I mean by that is, like, so for stuff like cleaning charts, we would attach cleaning charts to say equipment so that staff could very quickly sign off that it had been cleaned.
Okay.
But then we would have guidance that would say, no, they shouldn't be attached to the equipment, they should be kept in a folder. So we had to change everything. So it was like small things, but it was small things that were changing so much all the time, and it was hard for staff to keep up with that as well. It was hard for the managers to keep up with that. But it was hard also to cascade that to the staff. As I said, I had 40 staff. Not all of them were on Workplace, not all of them had emails. Trying to put information out and then bring that information back in for a change of guidance. Yeah. Because if one person didn't follow it, the perception was that no one was following it.
Okay.
So it was quite difficult to make sure that everyone was getting that information.
And so that was internal guidance,
yes,
rather than anything from the government?
It might well have came from government guidance, and we've like cascaded it down and made it Erskine guidance then.
Thank you. We've heard from others that they found NHS assurance team inspections and requirements to be inappropriate for care homes and to treat care homes like hospitals. Was this also the requirement, the experience at Erskine?
Yes.
And can you tell us about the requirements that were considered to be inappropriate?
Very much so. So Erskine and any care home will consider the care home as the resident's home. They were asking for very clinical setups. So they were asking for yellow waste bins at every resident's room. They were asking for separation of PPE. They were asking for PPE to come out of rooms. And it was, you know, it was sort of requirements that we couldn't always put in place for the residents. We had residents with advanced dementia. We couldn't police that. We couldn't. You can't tell a resident not to touch something, you know, all the time. You know, and it's a giant yellow bin. They're going to be attracted towards it. So it was very difficult, and it was difficult to explain to the assurance teams that we were someone's home. We wouldn't expect that in my home, so why should I expect that in a resident's home? Yes. But they were quite inflexible.
And at points did your directors have to get involved and speak to them about?
Yeah, so there was also differences between what the care inspector guidance was when they visited and the assurance teams. We were getting different messages, and we had to go back and question them a lot about who was telling us what to do, and, you know, could we get a consensus on it? It could be quite difficult at times. So
the dual inspection regime was causing more difficulties for you?
Yeah.
In paragraph 43, referring to residents, you state some of them forgot who their families were, lost social interaction, dining together and activities. Access to outside people such as dentists, podiatrists, dietitians was only available by telephone contact, not physical visits. What was the impact on your residents of on their mental and physical health of not having access to those sessions?
So I had residents who forgot who their families were. We had families who visited every single day and had like large families. To start with, there was no visiting at all. And it was done either through like tablet or online, and their residents couldn't always cope with that. They couldn't understand what was happening. When we did start doing outdoor visits, they had to be booked in. It was one person at a time, and again, our residents lost that contact with their families. We had residents who lost their communication skills. We had residents who gave up eating because, again, we were having to socially distance residents within the home as well. And when you've got a resident with dementia, eating and drinking is quite a social thing. They will copy each other, you know, so they'll eat better in a group sometimes, whereas we had to stop that. We had to have people eating singly, people eating in their rooms, so they were losing skills, they were losing communication skills. We were all wearing masks, which made communication difficult with the residents as well by that point. They weren't understanding us, they were scared, they didn't understand it. And also, yes, so we had no GP contact, we had no dental contact for 2 years. Dietitians, anybody else was by phone only. It was very, very difficult. We were lucky, Erskine's lucky they have advanced nurse practitioners employed by Erskine who can prescribe and could see the residents on site. But apart from that, we had no other advanced allied health professionals that could see them.
Did you have residents who developed problems with their teeth or feet?
They did, but we probably just dealt with it at the time. A lot of our residents, and it's just at that stage of life, they're either they have dentures or very few teeth. By the time people are living at home much longer, by the time they come to Erskine, they're much older. It wasn't always an issue, but people maybe had to change their diet because they'd lost weight, their dentures didn't fit, so they couldn't wear their dentures, so they were having to get like maybe a different textured diet, which isn't always the nicest thing either when you're, the only thing maybe you've got left is your food in your life, everything. Family's been taken away, recreation's been taken away, the only social thing you've got left is food, and that's changed as well.
You mentioned the on-site advanced nurse practitioners. Not, as you might already be aware, not all care homes were fortunate enough to have that. Do you think that having advanced nurse practitioners on site helped lighten the workload on your staff and improve the situation for residents? Were they able to get better care?
Yes, without a doubt, it was a massive bonus we had. We had 2 advanced nurse practitioners on site that worked all through the pandemic. They would come and they would see residents. If residents became unwell, they were very skilled, in treating those residents and giving us management plans for them. They were the ones who would order tests when tests became available to see if the residents had COVID or not. They were the ones who decided who was isolating. They could prescribe for us, they could prescribe just in case meds for end of life medication for us, they could have syringe drive for people who became really unwell. They did all of that, they were on site all the way through. They had contact with the GPs through the local GP surgery, but we didn't want for anything from a medical or a nursing prescription point of view all the way through COVID. It was a massive bonus.
Thank you. And you also mentioned in paragraph 46 that you had 2 GPs from Bishopton who did online calls. By that, do you mean video calls, or were they regular telephone calls?
They would either phone calls, or I think we had a couple of video calls for maybe some condition that they would need to see the resident, but they didn't come in, but they used our ANPs a lot for that, so they would liaise with the ANPs, and sometimes they would just sort of, have that conversation between them.
Thank you. Once Erskine resumed admission of new residents from hospitals or had residents returning from a stay in hospital, were there strict rules about residents coming in?
Yes. So we had to have 2 negative tests before they were admitted. Even then, we still had to isolate for whatever period it was at that time. So at the start, as I said, it was 14 days. It did get less and less as the pandemic progressed. But yeah, so we still had to isolate just to make sure that after the test they hadn't sort of contracted COVID. We had to make sure that coming for the hospital, that they were coming for a ward that didn't have COVID on it as well. It had to be like a green ward.
Okay.
And if they were coming from home as well, we had to ask for 2 tests before they were admitted.
Thank you. We heard from some other care homes that they were being sent patients who hadn't been tested prior to discharge from hospital. Did you have any experiences like that, or were your residents, did your residents all receive 2 tests?
To my recollection, everyone in Hague had tests before they came to us. Our moving in team were very strict on that. I couldn't tell you overall for the entire of Erskine, but as far as I can remember, Hague didn't have anyone who hadn't been tested prior to coming in.
Thank you. You mentioned in your statement your move-in team. Can you tell us a bit about them, whether they existed prior to the pandemic and how they were able to help during the pandemic?
So the moving in team was, it used to be called the admissions team, but our director of care is very keen that you don't get admitted to your home, you move into your home. So they changed it to the moving in team. The moving in team were a team of 3 people who, from first contact with Erskine right through to the person moving in on that day, they did all the contacts. They were the ones that made sure that the tests were in place. They would give us the assessments for the residents. We would assess them, and then they would sort all the moving arrangements from financial through to the tests, through to make sure they were eligible for Erskine. But one thing that did change with them is before the pandemic, if we assessed a resident, we always went and saw the resident. Once the pandemic started, then we had phone call assessments, so it was never the same. You never saw the resident before they were actually admitted to Erskine.
Thank you. In paragraph 52, you state that those residents who were transferred out of the care home by ambulance were emergencies and usually had DNA CPR decisions in place.
Yes.
We've heard from others that, from other care homes, that they were told there was a blanket ban on care home residents being taken to hospital by ambulance, or in some cases being taken to hospital at all. But that doesn't accord with your experience, is that right?
No, that's right. I can think of multiple residents who went to hospital for various reasons. Some emergency, or most, it was always emergency visits, but we never had an issue with getting residents to hospital if they needed to go. A lot of the residents we could help within the home, but there was always that sort of need for extra medical attention, and we never had an issue. The only issue we had was obviously that we always sent an escort with the residents, so they went with someone they knew. During the pandemic, that stopped. Even if they had no symptoms, they were still going to hospital without an escort, so it was difficult for the resident, and obviously it would have been difficult for the hospital staff as well.
And you say that in emergency cases you didn't test patients, is that right? You just informed?
We didn't. We informed the Scottish Ambulance Service if there was any symptoms.
We heard from others that some had an impression that some were given DNA CPR decisions so that they wouldn't need to be taken by ambulance or taken to hospital, treated by paramedics or taken to hospital. Why was it the case that at Erskine it was usually actually those with DNA CPR decisions who were transferred out?
Because, I mean, the vast majority of our residents already have DNA CPRs in place just because of the clientele that they are. But DNA CPR isn't a refusal for treatment. It's just that refusal right at the end. So we are always at the impression that if the resident has a good quality of life, if there's a good chance of survival, why do you not? You know, you're doing the best for that resident, so it doesn't matter if they've got a DNA CPR in place, we will still do treatment up to that point. And that was always our view there.
Thank you. And at any point, this is a final question for you, at any point in the pandemic, did a healthcare professional contact the care home and say that they would like to put in place DNA CPR decisions for all your residents?
Not that I'm aware of, but again, because of our residents' age, comorbidities, quality of life, then most of our residents already had DNA CPRs in place. We never had anyone who would push to say we should give them all blanket, but most of them already had that anyway.
Okay, thank you. Is there anything we've not, we of course have your statement and we'll take into account everything that's contained within it. Is there anything we've not covered today that you particularly would like to mention at this point?
I can't think so, no. I think we've covered everything. You know, it was just staff in care homes did the best they could at the time with the resources they had, with ever-changing guidance, you know, with residents becoming unwell. And again, these residents you maybe looked after for years, you know, they became like family too, you know, so it was difficult for the staff. I saw other managers who had seen half their residents pass away and sat at the bedside of every single one of them and looked shell-shocked. And, you know, it was just like, in a way I felt a bit of sort of like guilty syndrome because we didn't have that really in Hague. And there's another part of me that thinks to myself, we were the lucky ones. I don't know how anyone could stay locked down for 2 years in a house. We got to see other people. We got to speak to people. We got to, you know, take out our frustrations on each other that other people didn't have. So maybe lucky's the wrong word, but we had that social contact that other people didn't, and it made that camaraderie, which maybe got us through it. But no, apart from that.
Thank you very much.
No, thank you.
Yes, thank you very much indeed, Mr. McDonald.
Thank you,
Very
Lord.
grateful. Now we've finished early. I think that was anticipated, so there's no problem there. I'm not sure if the next witness is available to read. They're not. Right, fine. So maybe when it was anticipated 11:15. Yeah, we may be able to start a bit earlier than that. So apologies, I can't be more definite than that. Do what we can. Thank you. Mr Cascade.
Good morning, my lord.
Now, excuse me a second, when you're both ready. Thank you.
Would you tell the inquiry your full name, please?
My name's Wendy Bates,
And which organisation are you here representing?
Health in Mind.
And what's your position within that organisation?
I'm the Chief Executive.
And how long have you been there?
I've worked with Health in Mind since 2001 and in my current position since March 2019.
Okay. Can you tell us the nature of Health in Mind as an organisation?
Health in Mind's a charity promoting mental health and well-being. Most of our services are based in Edinburgh, the Lothians and the Scottish borders, but we do also have a number of national services covering all of Scotland, and we offer a range of support to people who have mental health difficulties.
Tell me about what it is that you do outside your core geographic area. What are your national programmes?
So we offer a telephone counselling service for people who have experienced trauma in childhood, and we offer training to organisations who are supporting people who have experienced trauma. And we're part of an alliance providing two services, Future Pathways and Redress Support. Future Pathways offers support to people who were abused or neglected in care in Scotland, and Redress Support supports people throughout the redress journey.
Okay. In advance of giving evidence today, you provided the inquiry with a witness statement. The part of the witness statement is on screen, and it's known by a reference number, which I'll just read into the record, which is SCI WT 0433501. The witness statement that's on the screen, do you recognise that?
Yes, I have.
Are you satisfied the content of that witness statement is true?
Yes.
And do you want to adopt that witness statement as part of your evidence to the inquiry?
Yes.
Okay. At this stage, I'm going to jump back and forward a little bit in the witness statement. Can I take you to paragraph 12? And you tell us there that you have a staff of around 140.
That's right.
And can you tell us what the budget is, just so we get an idea of the scale of the organisation?
Sure. Our annual turnover is around 8.5 million.
Okay. Going back now to paragraph 8, you talk about the history of the organisation, and you talk about the number of people that you support each year and the number of volunteers that you have. Can you just give us those figures?
Sure. So every year we support around 4,000 people with their mental health, and we involve 150 people as volunteers. And at paragraph 9, and I hate this phrase, and I'm sure Lord Brailsford will hate this phrase as well, but you provide in effect a mission statement for the organisation. Can you just tell us about that? So we provide, our organisation is a unique organisation because of the breadth of the work that we do, and we offer a unique pathway of support for people, and we also are committed to working in partnership with others as well to make sure that people who receive support get the best support available to them.
And paragraph 10, you provide us with a kind of definition of the focus of the types of work that your organisation does. Can you just tell us about that, the types of work that you do?
Yeah. So we offer trauma support, which is practical support with housing, budgets, relationships, as well as emotional support for people who've experienced trauma. We also offer a range of counselling, peer support, guided self-help, art psychotherapy, wellbeing groups, arts, nature and physical activity. And the the basis of a lot of our work is supporting people to build natural connections within their own community.
Right. Moving on again to paragraph 18, you talk about another part of your work. I'll come back to the earlier paragraphs in a second, but paragraph 18, you talk about your fundraising activities and trauma training. Can you tell us about that?
Sure. So 83% of our funding comes from contracts or service level agreements.
And is that with health and social care
That's right,
partnerships?
That's right, and the Scottish Government. And 7% of our funding comes from trusts, grants, fundraising and generating income. So one of the offers we have is trauma training, where we use the trauma training framework to deliver training to other organisations who might be supporting people who've experienced trauma in their childhood.
Right, and we know about that because almost all of the staff in the inquiry have undergone trauma training, but not with your organisation. No. At paragraph 14, you talk about the pre-pandemic situation. And I get the impression, and please correct me if I'm wrong, I get the impression from that most of the work that you did at that stage was in person.
That's right. Only a small proportion. Our trauma counselling line was delivered by telephone. All of our other support was offered in person, and staff worked from office bases. And
at paragraph 15, you give us an idea of the number of people that you provide support to. Again, can you just tell us about that?
So at the end of March 2020, we'd supported just under 4,000 people, and Future Pathways, which is one of the services we deliver through the InCare Alliance, supported a further 1,117 people.
And although it's not in your statement, do you have an idea of how those numbers changed during the pandemic period?
They increased slightly.
Increased. And how were you able to deal with that in terms of staffing and so on?
It was quite difficult because a lot of our staff and ourselves within the leadership team and our trustees were really aware of the unmet need of people within the areas that we work. What we did was we sought additional funding to be able to either recruit new staff or give our current staff additional hours to be able to support more people. At times as well, we changed the way that we were delivering services to offer more group support rather than one-to-one support, which meant we were able to support more people.
At paragraph 16, and this is not something that we've seen from many other organisations, you identify a danger in the type of work that you're involved in. Can you just explain that?
So it's really important that people we support don't become too dependent on our organisation or our staff. So all of the time we speak to people about when our support will end in order to really focus them on making their time with us count, and so that we can have the biggest impact on them. And that's why a lot of our focus is on supporting people to make natural connections within their local community or to use local resources, community groups. Some of that focus is on supporting people to be able to develop relationships with others, because we know a lot of people, especially people who've been abused in childhood, can struggle to make trusting relationships with others. So that's one of the focuses of our work, and it's really important that we're able to do that. And
one of the words that you use in that context is dependence.
That's right.
Avoiding dependence. Mm-hmm. Again, tell us about that.
Mm-hmm. Because we don't want people to become dependent on someone who's effectively paid to be in their life. We want people to have others within their personal social networks that they can call upon to support them. A way of not creating dependency is supporting people to develop strategies and skills and coping mechanisms for them to pull upon if they're starting to feel unwell or maybe feeling anxious, or being able to spot the early warning signs that they're becoming maybe more isolated within their life.
To use a well-worn phrase, you seek to teach people to fish rather than give them a fish.
That's right.
At paragraph 20, you talk about your involvement with the black and ethnic minority community. Tell us about that.
So as well as all of our services being inclusive, we have some particular services that are specifically for people from black and minority ethnic communities. We know that people from those communities can find it hard to access what you might call mainstream services because of issues with maybe communication, fear, stigma, cultural issues that aren't always paid attention to. And so our services that specifically reach out to people from those groups are delivered in a way that makes them more accessible to people.
And at paragraph 21, you talk about volunteers within the organisation. Where do your volunteers come from?
Our volunteers come from a range of different places, and some of our volunteers have used Health in Mind or other mental health services. Some of our volunteers are students who are looking to volunteer while they're at university. Sometimes our volunteers are looking to change their career or get experience to start their career. And others have family members who have experienced mental health difficulties, and it's seen as a way of giving back to organisations that have supported their loved ones. Now,
in the next section of your witness statement, which starts at paragraph 23, you have a heading, the pandemic. And I want to ask you to begin by outlining the immediate impact of the pandemic and lockdowns on you as an organisation and your service users.
Sure. So on the 16th of March 2020, we asked all of our staff to start working from home. This had a huge impact. We were really fortunate because we'd taken action to move a lot of our IT structures online to cloud-based Microsoft 365. So we were able to access a lot of our files and information online. But the issue was we didn't have the IT equipment to enable us to do that. Only a few of our team had laptops. The majority of our team worked from desktop computers. Some of our staff were able to take those computers home. Others weren't able to. And so in the initial days, some of our staff were working from a smartphone or their home computer until we were able to purchase laptops for everyone.
I'll come back to that later because there's a story about the laptops.
Yeah.
But essentially you moved from, in client dealings, you moved from one-to-one contact or group work into online work. Is that correct?
That's right. So one of the first things the staff team did was contact everyone they were supporting by telephone to let them know that we were still here, even though we weren't working from our office bases, and to offer support, offer people the opportunity to link in together, just offer that reassurance that we were still there for them, even though we weren't visible within our offices.
And for people you were involved with, either individually or in group work, was there a gap in the provision of service as you were making the transition from face-to-face to online? Can you tell us about that?
So there was a short gap within one of our services. There was a gap of a week, but during that time we were able to keep in touch with people, let them know what we were doing, give them assurance that we would be back in a position to support them very shortly. So the staff team worked really quickly to be able to develop new ways of working, safe ways of working online.
And were you, as Chief Executive, were you involved in training and training in particular for staff or middle management, if I can put it that way, in terms of providing those services in a new way?
The pandemic offered staff a real opportunity to show leadership throughout the whole organisation. Some of our team were really quick to get to grips with what was new technologies for us, like Zoom or Teams, and they were able to then develop guidelines that they shared with other staff. So that was hugely helpful for staff to really take the lead, and that it really was a strengths-based approach within the organisation rather than everything having to flow through myself or others within the leadership team. We did follow up that initial work with what we called netiquette training, which was training to support staff to be able to offer support online. So it ranged from everything from making sure people had like a blurred background or a virtual background when they were speaking to people, to just how to support someone online and how different it is to supporting somebody in person.
And within the organisation itself, how did the organisation switch into using technology?
So, for example, our board meetings moved to meeting online, and
how quickly did that happen?
It happened really quickly. Most of our trustees had access to laptops, and one of our trustees used to dial into our Zoom meetings via telephone, so it worked really quickly.
Right. And at paragraph 27, you talk about your leadership team meeting daily. Can you tell us about that?
It was important to meet daily to have and to keep a sense of connection and to make sure that we were sharing the same information across the organisation. It was important for managers to be able to check in to let us know about the progress they were making in redesigning services and to give us a report on the well-being of their staff and also any concerns that there might be for people accessing services or our volunteers.
Now, paragraph 28, you talk about something that happened on the 19th of March. Can you tell us about that?
Yes, on the 19th of March, our funders asked us to report to them how we would be delivering services for people.
This was before lockdown happened?
Yeah.
And how were you able to respond to those requests for information?
Because of our daily leadership team meetings, we had all that information to hand, so we were able to give a swift response to that.
Okay. At paragraph 31, you talk about starting a weekly email update for the volunteer team. Now, before I ask you about that, that was 24th March. Had you already set up some means of passing out information to your paid staff?
That's right. From the day that we started to work from home, I wrote a daily update to all staff, and on the 24th of March we started doing a weekly update to our volunteers. The daily update to staff included information that had been shared around guidance, but it also included a more personal input from myself, showing my vulnerability within the situation, and I think that was really helpful, or staff told me that was really helpful because they felt reassured that someone else was potentially feeling the same way that they were.
Mm-hmm. But you said that you started a weekly email for volunteers.
That's right.
And tell me, what type of information would that contain?
So that included information about how we were developing our services in relation to how they might be able to stay involved or change how they were involved to help us in a different way. but it also gave them some information and resources in order to support their mental health and well-being, because we knew some of our volunteers were in very vulnerable positions themselves.
You talk about paragraph 32, the kind of difference in approach in the initial stages where people didn't know if the lockdown was going to happen for a month or however long. Can you tell us about that?
Yeah, particularly within our counselling services, people let us know that they didn't necessarily want to move to being supported online or by telephone. They thought the pandemic might last a couple of weeks, and so they wanted to just wait and then pick up support in person again after the pandemic. We kept in regular contact with those people because as we got more information about the length that and then duration that the pandemic might take, we didn't want people to feel that because they'd said no once that they wouldn't be able to reconsider.
You talk at paragraph 34 about your relationship with the volunteer Midlothian. Again, can you tell us about that and what that organisation is?
So we were successful in our partnership bid to the Supporting Communities Fund with Volunteer Midlothian. Volunteer Midlothian's the volunteer hub within Midlothian, and we worked together to train volunteers across Midlothian, not necessarily to volunteer within health and mind, but to volunteer in lots of different organisations in lots of different ways. And our input into that was to offer mental health training to those volunteers.
And did that result in an upturn in the number of people who were volunteering, as far as you're aware?
Yes.
At paragraph 34, you say there were 150 new volunteers across the area. Was that just for Health and Mind, or was it for other organisations?
That was for other organisations.
And then you also talk at 33 about accessing additional funding. Yes, and then at 35 you talk about the outcome of that additional funding. Those two paragraphs are obviously related to one another. Can you just tell us about that?
So we were able to access a number of different grants from funding that was made available to support people. For example, the Community Response Recovery and Resilience Fund. We used funding from that to purchase additional Zoom licences for staff and volunteers to use. And we also used it to deliver wellness recovery action planning groups. And those groups focused on supporting people to identify daily and weekly wellbeing tools that they could use to keep well during the pandemic, and also early warning signs that they might be starting to feel unwell or experience distress. And we were able to offer for a short time a wellbeing line for young people in the Lothians and Scottish borders.
And why did that come to an end, as you indicated?
Because funding was short term.
And at 36 you talk about funders agreeing to refocus some of your funding.
Excuse me, that's right. We were able to involve our staff in different ways. For example, in Edinburgh we delivered a service that we called the Remote Response Service, and it offered short-term support to people who were impacted by COVID. And we also were able to use other funding differently to provide additional support to people whose lives had been impacted by trauma.
Okay. Now, at paragraph 27, you provide a date by which 90% of our counselling clients had moved on to phone or video support, and that date is the 27th of March. That's literally within days of the first lockdown.
Yeah.
Why were you able to move so quickly?
Being a charity or a voluntary sector organisation, we're able to move quickly and make changes quickly. We don't have lots of different layers of management or bureaucracy. We can move swiftly. We are able to, we're really close to the people that we work with, both, well, not at the time, but normally physically close in that we work within communities, but also we understand the communities that we work in, which helps us to be able to respond to needs that we've identified or people have told us about. In
terms of your recollection of events at the time, were statutory agencies able to move as quickly as you were?
No, it wasn't the case. And I think some of that was due to the fact that a lot of attention was shifted to people who were unwell, who had COVID and were dealing with symptoms of COVID. And a lot of our work is around early intervention. So my view is statutory services weren't able to move as quickly as we were.
Okay, at paragraph 41, you talk about providing online training for volunteers. And again, you say that was the 7th of April.
That's right.
Is that another example of the agility which your organisation was able to demonstrate? That's
right. So staff who were delivering the training were able to rewrite the training so that it was appropriate for being delivered online. They had to learn how to use Zoom, breakout rooms, whiteboards, different ways of working from the ways that we would when we delivered training in person.
And you talk at paragraph 43 about a positive aspect of moving online. Can you tell us about that?
That's right. So in addition to sending out a weekly written update to volunteers, we also were running a fortnightly online support space for volunteers. And staff and volunteers came together, and it was a social space, just a chance to get together, have a cup of tea together. And that resulted in people who would never normally meet. So, for example, volunteers in Edinburgh met for the first time with volunteers in the Scottish borders. And it was just a lovely way for people to spend time together with people that they knew and new people as well. And some ongoing friendships were developed.
Was that a positive aspect for the organisation?
Yes, it was really positive.
Okay. At paragraph 46, you talk about furloughing staff. How many staff did you furlough?
We furloughed 4 staff out of 140 staff. That was our 2 of our fundraising team and 2 people that we employed as office cleaners. We've
heard from a number of third sector organisations who spoke of redeploying rather than furloughing. Why was the decision taken in your organisation to furlough a small number of staff?
There's staff that we furloughed didn't have the skills or experience to be able to offer support. That wasn't the reason why we employed them. They had different skills that weren't required at that time.
Right. At paragraph 47, you talk about lending bikes. Tell us about that. That's just an interesting story from the pandemic.
So within Midlothian, one of the support activities that we offer is a cycling group, and we had 5 bikes that we lent to NHS key workers to support them to be able to get to and from their work when there was limited other ways for them to get there. And so we lent out the bikes to allow key workers to... But you had
to be conscious of a danger for the organisation in that?
Yes. We didn't want to inadvertently put the organisation at risk if something happened to one of the key workers when they were on our bikes. So, for example, if a wheel fell off and they injured themselves, we didn't want to be liable to that for that, so we had to get that checked out.
Paragraph 50, you talk about assisting staff and others with coping with the new normal, is the phrase that you use. Tell me what you did in relation to that.
So when the lockdown measures began to lift and we were able to have a little bit more freedom and we were able to support people in person and in groups, one of the things we noticed was that people were feeling really scared about being back out and in areas with large groups of people, for example, going shopping or parks and things were really busy at the time. And so our coping with the new normal groups offered people a space to share some of those concerns, and we supported people practically through breathing techniques to use if they started to feel anxious when they were out. Having a face covering, a mask, was difficult for a number of people that we supported, so that was really helpful to help with that feeling of panic, having the mask on.
Now, paragraph 52, you talk about the first 100 days of lockdown and your web activity as an organisation. Can you tell us a bit about that? That, I think, became quite an important part of what the organisation did.
That's right. So Health in Mind have our own website and social media channels, and in addition to that we have 4 information websites covering Edinburgh and then each of the Lothians. Our information websites include information about local services as well as more general mental health and wellbeing information, and both our own website and our information websites became hubs, a one-stop shop, if you like, for people during the pandemic, where they knew they could access the website and find out information about what was open, how they could access support within their local area.
You talk in at paragraph, and I'm going to jump forward, but you talk at paragraph 74 about people accessing your website, and at 73 about numbers again, but also being a one-stop shop. Tell me about that.
Sure. So in 2020, 2021, over 96,000 users accessed our information websites, and the definition of a user in terms of accessing the information is an individual, so it could be someone has returned a couple of times, but as I say, yeah, over 96,000 people accessed the information websites over that year. So I think that shows that they were seen as a one-stop shop for people to get reliable and up-to-date information.
So you were providing information, were you also passing people on to other organisations via the web? I don't mean in person.
So there was contact information there for people to be able to do that for themselves rather than us doing it. But where we were key was that the other organisations would contact us to let us know up-to-date information about the services they were able to provide and how people could access them.
And you talk about at paragraph 52 the number of posts that you put up as an organisation. 434 social media posts.
That's right, focusing on wellbeing and resources. So that was, for example, around our information that we developed around the 5 ways to wellbeing. So supporting people with practical tools and techniques to be able to support their wellbeing during COVID.
You talk at 53 to 55 about changes over time in relation to the guidance you were receiving. The early guidance was black and white, and later it became more nuanced. Can you tell me how, as an organisation, you coped with that?
Mm-hmm. It was really quite challenging. We had to be really careful to understand where and how guidance should be applied. Sometimes that involved checking our understanding with peers, colleagues, and at times the health and social care partnerships. What I did with the guidance was I had to interpret where our services sat within the guidance, because it wasn't always clear. So for example, for a day centre, it was really clear what the guidance was, but we didn't operate day centres. We weren't social work. We were somewhere, you know, it was sometimes quite challenging to find where our services sat. But so what I had to do was interpret where I felt our services sat. I then had to look at the risk appetite of our board, the needs of people accessing support, the safety of our staff, the safety of people accessing support. And in the end, it wasn't a one-size-fits-all across the organisation. We ended up with guidance that differed for different services that we were providing. So it became quite a complex picture. Sometimes, by the time we'd worked that through and we'd written our guidance for staff, the formal guidance had changed again. So we wanted to make sure we weren't lagging behind what the guidance was saying. So that was one of the main focuses for me during the pandemic, was always trying to keep ahead of the guidance or keep up to date with the guidance.
Listening to the answer that you gave, there were a lot of I's and me's and very few we's in terms of the organisation. Was the responsibility for dealing with the guidance, did that rest with you primarily?
As the Chief Executive, I held responsibility for ensuring the safe operations of our work, but I did liaise really closely with my colleagues within the leadership team, in particular the Deputy Chief Executive of Health and Mind. Please
don't name that person. I won't. And I think you wanted to say something about your deputy.
Mm-hmm. I think it just how important it was their input and support, both professional support and personal support, that we were able to offer each other during that time. We had a daily phone call to make sure that we were both on the same page, that we were both okay, and to highlight any issues or challenges that we were facing.
Now, you talked earlier about the shift from in-person to online and the use of laptops. Tell me about that.
So we worked out, of course, the price of laptops just skyrocketed at the early weeks of the pandemic. We worked out that in order to purchase the number of laptops we needed, we would need to spend £30,000. We had decided, the board had agreed, that we would take that money from organisational reserves.
So you were going to eat into your reserves to meet that £30,000
That's right. Because,
outlay?
Yeah. Because it was a non-negotiable, we needed that equipment to be able to support people. But we were really fortunate in that we actually received a donation from someone who wanted to cover the cost of those laptops for us, so we didn't have to use reserves in the end.
Now, you say in your statement that person doesn't want named, and I'm not going to ask you to name them or identify them, but was that someone who just effectively, out of the blue, said, have this £30,000 to buy your laptops?
It was someone who had a connection to the organisation already and was really wanting to help, and had asked, well, what's the best way that I can help you?
And that person doesn't want identified?
No.
Paragraph 56, you talk about facilities for staff, particularly those working at in their own home. Tell us a bit about that.
Asking staff to work from home was really challenging, especially for a number of our staff who lived in shared accommodation. So the only private space that they had was their bedroom. So we were asking people to support others, hear and hold the pain of others within their own private personal space. And it was really challenging. Other staff maybe had a bit more space, but then had homeschooling on the go. Others had other caring responsibilities. Altogether, it was a real juggling act for our staff team. We are normally really clear about the boundaries between work and home, and it's really important because of the work we do that we don't take the work home. But in fact, work was home during those months, so it's extremely challenging for the staff.
And how, as a management team, did you respond to that?
Where we could, we were able to help in practical ways. So, for example, purchasing desks or chairs for people if they needed it. We're also, in terms of emotional support, we upped the amount of support that we were giving staff. We encouraged everyone to take their daily walk during their lunchtime to make sure that they weren't only at home, and to try and find some way to split the work day and the rest of the day.
You also talk about concerns in relation to data protection.
That's right. Information security is really important to an organisation like Health in Mind, where we're dealing with and handling a lot of personal information. We drew up new guidance for staff working from home to make sure that they were taking necessary steps to protect the personal information of people we were supporting. That included everything from purchasing headsets so other people within their home wouldn't hear what was being said, to making sure security patches were updated on laptops, making sure that there was no names used if people were writing notes before they uploaded them onto the cloud, things like that.
Another area which caused concern for the organisation was Scottish Government's £250 recognition payment for people involved in caring, stating that broadly. Were some of your staff able to access that?
Some of our staff were able to access the 250 payment, but other staff weren't. And at a time where all of our staff had given so much of themselves, we didn't want to cause any feelings of not being valued or not being recognised for what people had given. So our trustees decided that, again from charity reserves, that we would offer give the £250 payment to all staff within the organisation, rather than just those who are working within services that were registered with the Care Inspectorate.
So those who weren't getting it from the Scottish Government got it from the organisation?
That's right.
So everyone got £250?
Yeah.
You then talk about several of your staff testing positive for COVID. What impact did that have?
We were fortunate in...
On the organisation?
On the organisation. We were fortunate in that we didn't have large numbers of staff being infected at the same time. We were able to cover support, but what that did mean was that other staff within the team had to do more in order to cover for people who were off sick.
And at 65, you talk about providing additional support to staff.
Following, following the, well, I was going to say the end of the pandemic. I'm not sure if I would necessarily call it that, but we offered reflective sessions for our staff to be able to just have a safe space that was externally facilitated, a safe space to be able to talk about the impact that COVID, or working throughout the COVID pandemic, had had for them. And we were also able to tap into some Scottish Government initiatives like Coaching for Wellbeing, which was available to staff, all staff.
Unusually, your organisation is slightly self-critical about the reflective period that you've given to staff. Can you tell us about that self-criticism?
It's my view that we did the reflective practice sessions too quickly. That people were still, our team were still kind of in the throes of what they had experienced, and if we had waited 3-4 months to offer the reflective practice sessions, I think it would have been more beneficial when people had more space to really consider the impact that working through the pandemic had had for them.
And you talk about at 66, staff were also impacted by the knowledge they were unable to meet needs within the community. Tell me about that.
So every day we were getting telephone calls from people that were looking for support, people in distress. We were receiving referrals for people from third parties on behalf of people who were looking for support, knowing that waiting lists were growing while staff were working as hard as they could and to full capacity was really distressing for staff, and it was just this feeling of never doing enough. And I think that was particularly evident within our Future Pathways service, which was for in-care survivors, where we just were never able to meet the needs of everyone who wanted to access support. It was really difficult.
At 67, you talk about additional support for our team. Tell me about that and the longer term impact of the pandemic on your team.
So 2 people have left the organisation because they were no longer able to work because they had long COVID, and the lasting impacts of that meant they didn't have the energy or capability to be able to keep working. We also noticed that we've lost or more staff. We've had a higher turnover than usual since the pandemic. It's not a significant number, but we have noticed an increase in turnover of our staff.
And prior to the pandemic, were you an organisation with low staff turnover?
Yeah, our turnover has always been under the national average.
And now?
And now we're still slightly under, but it has grown.
Okay. You tell a strange story, paragraph 68, regarding PPE and testing kits. You say there were no problems with PPE.
Yeah, there was no problems with PPE, and there was certainly no problems with testing kits, because we received huge boxes of testing kits, and they just kept coming and kept coming and kept coming.
Where from?
We don't know.
We just arrived out of the blue.
Yeah.
Bizarre.
Yeah. We looked on there was no real information on the boxes apart from the postage. We contacted the distribution centre. They weren't able to tell us where they came from, and it ended up we had cupboards and cupboards full.
I mean, you're talking hundreds or thousands?
Thousands. Well, 1,000. But certainly lots, more than we could have ever used. And so what we were encouraging all of our staff to use them, obviously, that staff could share them with people accessing our services, volunteers, and we work in a shared building. We offered other organisations, and it's a shame because actually some of the test kits went past their expiry dates, and we had to just, well, recycle what we could and throw out the rest. And to this day, we still don't know where they came from.
It's very strange, isn't it?
At paragraph 70, you talk about the impact on volunteers, and we've heard from a number of sources that the desire to be a volunteer increased during the pandemic. Can you reflect on that for us?
We did have some increased interest in volunteering with us, but because of the nature of the work we do, we have to make sure that we have proper checks in place. So that includes reference checks, interviews, application forms, and we also ask for PVGs. And what I mean by PVGs is for people to be a member of the Protection of Vulnerable Groups scheme, in which Disclosure Scotland undertake police checks to help us decide if someone's suitable to work with vulnerable people.
You described that, and then did that have an impact on well, that must have had an impact on your requirement to conduct training?
That's right, because we need to have all of those checks in place, ideally before we start training, and the same is the case for our staff team. Staff, in terms of people becoming PVG members, staff in key roles were being prioritised by Disclosure Scotland, and so volunteers were slightly further back in the queue, so it meant that there was quite a long gap in getting PVGs back. The Care Inspectorate published some advice on risk assessments where PVGs weren't available, and we did follow that guidance, although I felt really uncomfortable not having that final piece in the recruitment puzzle and having a PVG police check back for people because of the nature of our work.
You talk about, I'm looking at paragraph 72, you talk about additional support for volunteers, and there's a quote there. Could you read from the quote to the end of that paragraph, please?
Sure. So one volunteer said, "When COVID first struck, I found it an extremely lonely time. Very quickly, Health and Mind started a Zoom group for volunteers. It meant such a lot to me that we were not forgotten about, even if our usual role was not needed at that time." The message received from this by me was that we were important enough to the organisation to be remembered.
Was that an important thing for you to hear and for the management team to hear?
That's right. All feedback was really welcome during that time. Things that we were doing well, things that we could do better, things that we should really stop doing, things that we should start doing. All of that feedback was really helpful.
At 73 and 74, you provide figures, and I think you've already provided many of those figures, so I don't need to get you to repeat them. But you do talk about problems with referrals at 75.
That's right. So the pathways into our services are different. Some of our services people can self-refer, so they just get in touch with us. But other services require a third-party referral. So that's a referral from a GP, a social worker, another voluntary organisation. And there was some delay in receiving referrals due to being able to safely transfer data, personal information. So, for example, any referrals that came from the NHS had to come by letter, but letters were being sent to our offices and there was no one in the office to receive the letter. We did start to go in on a semi-regular basis to pick up post, but then when restrictions eased, we were able to be there to get the referrals. But I guess it's another example just where we were able to work a bit more agilely.
With more agility?
With more agility, thank you, than some of our statutory sector colleagues.
Okay. Could you read paragraph 76 aloud, please?
As was said during the pandemic, although we were all in the same storm, we were all in different boats, and this was especially true for people accessing mental health support. Mental health issues were compounded by the fear of COVID-19, issues of isolation and being cut off from essential connections, and underlying issues of stigma, social exclusion, inequality and poverty.
And read on into paragraph 77, please.
For some of the people we supported, they were left totally on their own, with no family or friends to connect with. Our team were the only people they were in contact with. Others found themselves in equally challenging situations where they were spending extended periods of time with people with whom they had relationship difficulties. This too significantly impacted mental health and well-being.
At paragraph 78, you revert to talking about BEAM clients. Again, can you tell us about that and what you're saying there?
So, as I mentioned previously, there are a number of barriers to people from Black and minority ethnic communities accessing support, and these were heightened during COVID, and they felt really insurmountable for some people. What made it more difficult was there was a lot of media coverage around at the time about increased risks for people from BAME communities, which also added additional concerns and worries on top of the concerns around the pandemic more generally.
I'll move on. You talk about additional challenges, and at paragraph 82, you talk about a feeling of discomfort arising from something. Mm-hmm. Can you tell us about that?
So, because of my role, I was able to work from home throughout, but it felt really uncomfortable where I was asking staff to be out working with people and supporting people, and also our business support team who were travelling to the office to check on post and to answer phone calls. So there was some sense of discomfort and the lack of equity around that.
Could you read paragraph 85, please?
It was easier, and I've put that in inverted commas, to manage the organisation where there were clear boundaries and restrictions in place. As directives allowed for more individual choice and organisational discretion, it became more challenging to balance the needs of people accessing support, staff, volunteers, and other stakeholders such as funders.
And at 87, you indicate that there were really, amongst your staff and volunteers, two different types of attitude towards coming out of lockdown. Can you tell us what those were?
That's right. So some of our team were really raring to get going, couldn't wait to get back out to support people in person, felt that at times our approach was being too cautious, and there was another group of staff who were really frightened and scared that they might become ill if we went too quickly and we returned to in-person support too fast without appropriate measures in place. And then we had a group in the middle who were kind of, oh, well, I don't know, but I would say most of the staff fell into those two groups.
The extreme ends of the spectrum. At 88, you talk about effectively altering job descriptions for your staff. Tell us about that and why you did that.
So we, by April 2022, we'd amended role-specific risk assessments for all of our staff. And that was to make sure that as we returned to in-person working, that we had the proper, we'd identified and managed the risks appropriately. We'd also opened back up our offices at that point, but with reduced capacity. So we had to develop new systems for planning ahead who would be in the office when, to make sure that that was well managed and we weren't too close together. Paragraph 90, you talk about the changes that the pandemic has had on the organisation overall. Again, can you just tell us about that? So there has been a really positive change in that we're now able to offer people support in a range of different ways, either in person, online or by telephone. Some people want to be supported by all three of those ways at different times during their support journey with us. So that includes group work and individual support. So that's been really positive to be able to develop those skills to work with people differently in line with their needs. At 99, you talk about the overall demand. Sorry, 92, you talk about the overall demand for the service. Tell us a bit about that. So demand continues to be high for all of our services, especially counselling, art psychotherapy and trauma support. Waiting for any kind of mental health support can be really problematic because it's really important to be available for someone when they're ready to engage with us. If we wait too long, that time might have passed, and their mental health and well-being might have deteriorated during that time. So again, it's a real sense of discomfort knowing that we can't support everyone that needs us. Give me just 1 second. And have you seen delays in accessing services within the statutory schemes increase? Yes, yeah. It's certainly anecdotally from people that we support, they talk about statutory services feeling less available now and having to wait longer for those services than they had previously. And at 93, you talk about the longer term impact on your staff. Mm-hmm. Again, can you tell us of that? At the beginning of the pandemic, we were kind of working on adrenaline. It was new, it was different. We were able to tap into new skills. There was leadership across the whole organisation. And although it was an extremely difficult and challenging time, there was some positives within it for us as an organisation. But as time went on, where people didn't have a real break, there's a real sense of exhaustion, of tiredness. I think the impact of Brexit, the cost of living crisis, increased inflation, the war in Ukraine, climate crisis, it just all feels really heavy for our staff team just now, and just this a real sense of tiredness. You then talk about lessons learned, and all of those will be read carefully by Lord Brailsford, and he will take account of your suggestion for lessons learned. But you highlight a couple of points, or I want to highlight a couple of the points. First one, you've already told us about in some detail, is at paragraph 97, and the difficulty with the £250 payment and the inequality from Scottish Government in relation to that. Do you want to say anything else about that? No, I think I've covered everything.
Okay. Could you read paragraph 98 aloud, please?
Ensuring time was taken to plan for each stage of the pandemic was challenging, ensuring we were keeping up to date with changes. Because it was an evolving picture, just as plans were being shared and embedded, they changed. This added a great deal of pressure whilst also managing day-to-day operations within the organisation. Staff felt the impact of working within an environment of constant change. This became draining on their energy and resilience levels.
Okay. You state some hopes for the inquiry. Can I just ask again that you read aloud paragraph 105?
I hope the inquiry is a space where we can recognise all that individuals and groups gave during the pandemic.
And then 104.
It is important that we do not only view through the timeline of the... Sorry, I've just... It's important that we don't only view the timeline of the pandemic through the lens of what we know now, but also based on the information we knew at the time. However, it is important that the inquiry is clear about mistakes that were made to ensure they do not happen again in the future.
And I think those are all the questions I have for you. I indicated before we came in that when I got to the end, I would say, is there anything that we've not covered? Is there anything that we've not covered?
Just wanted to just talk a little bit about the amazing efforts that our staff team put in during the pandemic. It was a really difficult time for everybody as we were experiencing such loss, grief, anxiety about so much that was unknown to us. For our staff team to be experiencing all that personally and also to support others who were experiencing the same was quite a feat. And I actually can't thank our staff team enough for everything that they did. The leadership that was shown across the organisation was just phenomenal, and it just really reminded me of how wonderful human nature is.
You're not the first chief executive of a third sector organisation to say that. Mm-hmm. I don't have anything else. Thank you very much for coming along.
Thank you. Thank you.
Yes, thank you, Ms. Bates.
Thank you.
Very good. 1:30.
1:30.
Thank you.